Hello everyone and welcome to another session of next Saviours Essential Question Series NEET PG 2025. We genuinely feel that this year they are going to ask you a question out of the differential diagnosis of the hip pain, like tuberculosis of the hip, like osteonecrosis of the hip, like osteoarthritis of the hip, and this is exactly what we are going to talk about. Like the first question is, a 34-year-old male presents to the OPD with the complaints of progressive pain in the left hip for the past 4 months. Now, there could be a duration which could be insidious, which could be immediate, which could be of short duration, but here it is an insidious duration. That means a long duration of around 4 months. This is the first hint which is always provided to you in the question, and subsequently you will come to know that how this hint is particularly important. Now, he reports difficulty in walking and experiencing pain while climbing stairs and getting up from the seated position. This majority of the times or in general remains the same, although the variation could be there in the form of that what comes first. Like in some of the cases, limping come first. In other cases, there could be pain that comes first. So that is the second hint, that what is the characteristic of the pain which is provided in the question. Next is that there is no history of trauma, but he mentions long-standing use of oral glucocorticoids for the previously diagnosed autoimmune disorder. Now, for lupus vulgaris, for any other skin condition, for allergy, there could be a possibility that the patient had a glucocorticoid and there is a long history. Now, this is the third important point in the form of a hint which is provided to you in the question, because this third point is actually pointing out towards the etiology. And then on physical examination, there is a restriction of internal rotation and abduction of the hip. What the routine investigations are within normal limits, what is the most likely reason for this, and this is the fourth hint on the basis of which you will conclude the diagnosis. And if the x-ray is provided to you, obviously you have to look at the x-ray and you have to mark the correct answer related to the diagnosis asked. So once we read the question out, now we have to deal with each and every option which is provided to you in the question and finally conclude the answer. Now let us talk about the pathophysiological mechanism of the osteonecrosis of the hip joint. Now all of us are aware of the fact that head of the femur is intracapsular. That means it is lying inside the capsule. Now imagine if there is a fractured neck of femur, or imagine if there is a dislocation, or because of any other reason there is a decreased blood supply or vascularity. Now what will happen? Because of this fractured neck of femur, there will be collection of the blood inside the capsule. That means intracapsular pressure will be raised, and this raised intracapsular pressure will result in the compression of the capillaries further inside the head of the femur. That is why there will be raised intraosseous pressure, and this raised intraosseous pressure will compress the capillaries, as a result of which will be no vascularity, and once there is a vascularity, it will undergo necrosis. So that is the pathophysiological mechanism of osteonecrosis, head of the femur. Next is the another important differential diagnosis is the tuberculosis of the hip. Now, what is the pathophysiological mechanism in those cases? You already know that this is the acetabulum, this is head of the femur, GT, LT. Now, what happens is majority of the time the first part to be affected is the acetabulum by the tubercular organism. Now, this TB over a period of time, it will encroach to involve the synovium, and from the synovium it will encroach to involve the head of the femur. That means the entire hip joint will be affected subsequently. Now what it will do over a period of time, that it will eat away the synovium, so there will be reduction in the joint space which appears early. So this reduction in the joint space, it appears early in comparison to what we have seen in case of osteonecrosis. So this is in short about the pathophysiological mechanism of these two things. Now, once we have understood the pathophysiology of these two important differentials, now is the time to understand about the causes, that what are the possible cause behind this. As we have just talked about, for AVN, that means osteonecrosis head of the femur, it is resulting from the ischemia that leads to bone necrosis. And among the causes which are required, or among the causes which could be the reason for this, are the trauma. If there is a fractured neck of femur, if there is a fracture of the head of the femur also, if there is a dislocation of the hip joint, or if there is even a fracture of the acetabulum, it might all result in AVN, head of the femur. Then the second most important use which is usually kept in your questions are the steroid used. Now, this could be used judiciously. Like, for example, if the patient was suffering from certain disease, and for that it was indicated that the steroids are to be used. Another reason is like a person is a bodybuilder, because these are the hints which could be provided to you, and is taking steroids in order to, or is taking anabolic steroids in order to increase in his muscle mass. So that could also be the cause which could be provided to you in the question. Apart from this are the alcohol use. Although the most common reason remains idiopathic. Idiopathic means that no identifiable cause is there. But practically what is seen in OPDs, in orthopedic practices, that alcoholism is the most common cause practically. Apart from this, there could be sickle cell disease, because sickle cell disease, the viscosity of the blood flow is increased, and because of any minor event, it might result in complete cessation of the blood flow. Then Kaizen's disease, that is deep sea diving, where the entire human body is under too much of the pressure, and because of this, there could be a possibility of osteonecrosis. Then are the other one like SLE, the Gaucher disease, some metabolic syndromes, or the radiation. So these are the causes. Among the causes for that particular question of osteonecrosis, trauma is important, alcohol is important, and steroids are important. Now, if you go back to the question, the third hint which is provided to you is a cause that there is no history of trauma, but the patient was on glucocorticoid because of some autoimmune disorder he is suffering from. So that is a cause which you are going to add as a hint for concluding the diagnosis. As far as tuberculosis is concerned, you already are aware the cause is Mycobacterium tuberculosis, and it is responsible, and the hip joint is affected as a secondary joint because of the hematogenous spread. Osteoarthritis, it could be primary or it could be secondary. Even AVN can result in osteoarthritis. Even tuberculosis of the hip joint can result in osteoarthritis. Means ultimately, if the disease is allowed to progress without any intervention, then all of these diseases will result in osteoarthritis. So cause is particularly important for osteonecrotic reasons or osteonecrotic questions. Next are the clinical features. Step-by-step guidance of the clinical features, or the important hint which could be provided to in the clinical feature. One is limping, that the patient starts limping along with pain. Now, the characteristic finding over here is that limping usually coincides with the onset of the pain. It's not like that the pain comes first and the limping comes subsequently, or the limping comes first, then the pain comes subsequently. So both of them are going to be correlating with each other, because the patient will give you a long history. Like, the history will be practically more commonly around 9 months, 1 year. This is how the history goes. Now, the most important point is that there will be limitation of abduction and internal rotation of the hip joint. You already know that the six movements around the hip joints are abduction, adduction, flexion, extension, internal and external rotation. Now, there will be restriction of the abduction and internal rotation of the hip joint, on the basis of which clinically you can make the diagnosis. Now, if you go back to the question, then as a fourth hint which is provided to you are that there is a limitation or restriction of internal rotation and abduction of the affected hip. So possibly we are dealing with the question of osteonecrosis of the hip joint. So this is one important clinical feature. Apart from this, the third one, in the late of the course, there could be a shortening. All right. So shortening might or might not be present. It depends upon the stages in which the patient is presenting to you. So we are restricting ourselves in the discussion of how to differentiate these 3 to 4 clinical hip pathologies. We are not talking about all the stages of the osteonecrosis of the hip joint. So these are the clinical features that you have to remember. Point number one, the pain and limping, which will be common in all of them, but here there will be a long duration. Second is the limitation of abduction and internal rotation, which is specific for osteonecrosis of the hip joint. The tuberculosis of the hip. What are the clinical features? So the clinical features, it runs in stages. The stage 1, stage 2, stage 3, and finally the stage 4. So what is the first stage? The stage is that of the stage of synovitis. Now, what do you mean by the term synovitis? Synovium is the joint. Itis is the inflammation of the joint. That means there will be an inflammation of the joint. Now, hip joint is a closed space, and if there is too much of accumulation of the fluid inside this closed space, then the movement obviously are going to be painful. So the patient will acquire the attitude where the hip joint is having the maximum possible space, and that attitude is that of the flexion, abduction, and external rotation. So in the first stages of the TB hip, the how the patient will be presenting to you, the hip joint will be kept in or would be slightly restricted in flexion because it increases the joint space, abduction because it increases the joint space, and external rotation because it increases the joint space in order to accumulate that excessive fluid. Now, what will be the possible limb length? How the limb will appear to you as lengthening is concerned? So you see, there will be apparent lengthening of the limb. Why there will be apparent lengthening? Because when the hip joint is abducted, try to understand this with this image. Like if the hip joint is abducted and the other one is normal. So in order to put both the feet on the ground, that means in order to have bipedal stance, the pelvis on the affected side will drop down. So this drooling down of the pelvis or dropping down of the pelvis will make the limb appear longer in comparison to the normal, although when you measure it, both of them are of same size. So that is why it is called by the name of apparent lengthening. The second stage is the stage of early arthritis. Now, you know what happens that over a period of time, the synovium will be eaten away by the organism, and the bone, the nerve endings of the head of the femur will be exposed to the acetabulum. The nerve endings of the acetabulum will be exposed to the head of the femur, and as a result of which, there will be pain on movement. So, in order to limit this movement, what the patient involuntarily will do, or what the body will involuntarily do, that it will restrict all the movements of the hip joint. And once it is restricted because of the spasm of all the muscles, the hip joint will acquire the attitude of flexion, adduction, and internal rotation because the flexors are stronger in comparison to extensors. The adductors are stronger in comparison to abductors. The internal rotators are stronger in comparison to external rotators. And that is the reason why the limb goes into flexion, adduction, and internal rotation. Now, here because the limb has moved into adduction in order to have the bipedal stance, the pelvis on the affected side will obviously ride up. So when such a patient is made to lie supine on couch, then the affected limb will appear slightly shorter in comparison to the normal. But this is the stage of apparent shortening because the length of both of them are almost equal because this is the early stage of arthritis. Then coming on to the third stage, that is advanced arthritis. Now, over a period of time, what will happen? That the hip joint will be eaten away by the organism. The head of the femur will become smaller, smaller and smaller. There will be loss of joint space also. So the attitude will remain the same. That is flexion, adduction, and internal rotation with the increased severity. Like there will be more flexion, there will be more adduction, there will be more internal rotation. And this time, the patient is going to have a true shortening. Now, over a period of time, what will happen when the head of the femur will become too small to be retained inside the acetabulum? There is a possibility of dislocation. So, finally, it ends with dislocation of the hip joint. So, these are the clinical features of the tuberculosis of the hip. Now, for a question related to TB hip, there has to be either a specific stage which should have been mentioned along with the constitutional features in the form of pain more at night, the limitation of the movement while working, shorter duration of symptoms in comparison to what we have discussed in case of osteonecrosis of the hip joint. So these are the things on the basis of which you will conclude the diagnosis. But none of these features are presented to you in the question. And finally, the clinical features of the osteoarthritis hip are simple. That means there will be movement. So there will be difficulty in squatting, there will be difficulty in cross-legged position, sitting in cross-legged position. The patient will be having a very slow duration of time, and in particular, if the question is asking about primary osteoarthritis, then the patient obviously would have been an elderly patient. So these are going to be the clinical features for osteoarthritis of the hip. Although we have to restrict ourselves in discussing the major two differentials, that is osteonecrosis and tuberculosis of the hip joint. Now we shall come on to the discussion of the X-rays, the most important part of the question, that is X-rays. If you look at the osteonecrotic head of the femur X-rays, then if we go stage by stage, then what is happening first is that if this is the head of the femur and this is the GT, this is LT, So because of the osteonecrosis, the head of the femur, which is articulating surface of the head of the femur, it will become sclerotic. Why it will become sclerotic? Because the fourth stage of apoptosis, that means fourth stage of necrosis, there will be there more calcification, the dead tissue, and it will become sclerotic. It will appear sclerotic. That is point number one. That is early sign of osteonecrosis head of the femur. The second stage would be because the patient continues to bear weight on this weak head, then obviously there will be a appearance of the subchondral fractures at the head of the femur. Now, this head is obviously weak, and if the patient continues to bear weight, then there will be appearance of the subchondral fractures, and this subchondral fractures of the head of the femur are also known by the name of crescent sign. Now, this is one very important finding which is theoretically very frequently asked, but this time there is a possibility that they might give you it in the form of a question. Like, this is how the subchondral fractures looks like. If you look very carefully in this image in particular, so these are the fracture lines which are happening in the subchondral, means below the level of the cartilage. That means in the articulating surfaces of the head of the femur. So that is crescent sign. Now, over a period of time, what will happen if the patient continues to bear weight on this weak limb or the weak head of the femur? Then there will be a loss of sphericity, and this loss of sphericity will lead to progressive flattening. So there will be progressive flattening, as it can be very easily identified over here, that there is a loss of sphericity and almost flat head of the femur. And over a period of time, what will happen because of the increased horizontal vector force? So there will be lateral subluxation of the head of the femur out of the acetabulum. So these are the X-ray findings which are very easily identified. But the most important things on the basis of which you will identify this X-ray when you are presenting, when it is presented to you in the examination, is that one is that the head of the femur is flattened, which is very easily identifiable. But the second point is that there is no reduction in the joint space till the last stages. You know, until and unless the stage of secondary osteoarthritis comes in, there will be no reduction in the joint space. And this is how exactly you are going to distinguish it with the tuberculosis of the hip joint. Now, in the tuberculosis of the hip joint, the reduction in the joint space is the earlier finding. So, how you are going to distinguish these two X-rays? In case of osteonecrosis, there is no reduction on the joint space in up till the last stage, because in the last stage, when the secondary osteoarthritis comes in, then there will be a reduction. But here, in case of tuberculosis of the hip joint, there will be a narrow joint space, which is the earlier finding. Apart from this, there will be periarticular osteopenia. That means peri means around, articular means joint. So around the joint, reduction in the bone density, osteopenia. And erosions, that means articular margins are eroded. So this is how the X-rays of the tuberculosis of the hip joints are identified. There are some named X-ray findings also, like wandering acetabulum, where the head of the femur becomes too small, and if these two becomes incongruent, so it is called by the name of wandering acetabulum. So apart from this, there are some named findings which are nowadays not very frequently asked, like wandering acetabulum, that when the head of the femur and the acetabulum becomes incongruent, they seem to be having no relation as far as the surface area is concerned. And the other one is pestle in motor appearance, where the head of the femur becomes too small that it appears like a pestle in motor. That means appearance of the Oakley. So these are the two named findings which are not very frequently asked. All you have to remember that how on the basis of the X-ray you will be differentiating in between TB and osteonecrosis head of the femur. And then in case of osteoarthritis hip, obviously there will be destruction of the head, there will be destructive features of the acetabulum, there will be reduction of the joint space, there will be periarticular erosions, there will be secondary osteophytes. So all these are the findings on the basis of which you can very easily identify the osteoarthritis image. Now, once you have, so let's revise that what all we have talked about, that how you are going to distinguish in between the osteonecrosis head of the femur and the tuberculosis of the hip joint in particular. For osteonecrosis of the head of the femur, there has to be a cause. For TB, obviously the constitutional features are going to be there. For osteonecrosis head of the femur, there is a clinical feature in the form of limping and pain of a longer duration in compared to TB, while there will be limitation of abduction and internal rotation, while in this case of TB, there will be an attitude of hip joint specific to the specific stages. As far as the routine laboratory investigations is concerned, in case of avian, it might come obviously normal, but in case of tuberculosis, there could be a presence of lymphocytosis, there could be a presence of raised DSR, there could be a presence of um, Monto says positivity, right? And finally, on the basis of the X-rays, in X-rays of the osteonecrosis of the head of the femur, there will be a flattened sclerotic head of the femur without any reduction of the joint space until the last stage comes. While in case of tuberculosis of the hip joint, this reduction in the joint space along with the periarticular osteopenia is usually the earlier finding on the X-rays before the settings of the osteoarthritis. So once we have made the diagnosis, now they ask you about the management of the osteonecrosis head of the femur. You know, the drugs which can be used for the management are the alendronate, that means the bisphosphonates. Why? They Because they are responsible for progressing the they are responsible for limiting the progression of the disease. All right, they cannot cure the disease. Then enoxaparin, then the hyperbaric oxygen, right? So these are the, or statins, they are responsible for, they limit the progression of the disease, they cannot cure the disease. And these two are indicated, that means the drugs are indicated only before the pre-compression stages. That means the head is spherical. Second is the core decompression. Now, what do you mean by the term core decompression? Decompression, as you know, decompress. That means you are relieving the compression. Now, what are getting compressed? The vascularity. How you are going to relieve it? By introducing the drills and drilling it multiple holes in the articular surface where the sclerotic rim or the sclerotic region of the head of the femur is there, thereby reducing the intraosseous pressure, and hope that there is going to be a revascularity. But that too again can be done in the pre-collapse stage only. That means where the head of the femur is not yet collapsed. Now you can do core decompression alone, or it can be coupled with the it can also be coupled with the strut fibular grafting. Like this is how the fibular grafting looks like. Here you have taken the patient's fibula and inserted inside in order to provide the strength to this head of the femur that is about to get collapsed. So that is core decompression. But remember, indication for core decompression is pre-collapse stage. Once the head of the femur is collapsed, then you cannot do core decompression because it is not going to help you out in regaining the shape of the head of the femur. In that case, you have to go for the total hip replacement only. Right? So this is how the management of osteonecrosis head of the femur is done. In case of tuberculosis of the hip joint, obviously you have to start with the ATT plus absolute bed rest so that you are not bearing weight on that affected limb with or without traction. Now, what the traction? Because traction is responsible for relieving the contractures of the muscles and thereby preventing the adhesions of the joint. Now, this is for the initial stages, but what if the secondary osteoarthritis has already damaged the hip joint? Now, in those cases, you can either go for the hip replacement. That means you have to replace the acetabulum, you have to replace the head of the femur and provide the artificial joint in between. But that hip replacement can only be performed after 6 months of initiating the anti-tubercular drugs, because the possibility of infection at that of the implant is too high. And the other possibility is girdle stone arthroplasty. What is girdle stone? That means you remove the head of the femur, you remove the affected, or you debride the entire affected joint, and then you put the patient on skeletal traction for the period of 1.5 months. Don't ask him to bear weight for the period of 3 months, and then over a period of time, the fibrotic tissue will develop, and then the patient can walk. But it will come with the disadvantage of shortened limb and unstable limb. Although the patient can walk, but there will be a shortening, there will be a persistent limping because you have removed the head of the femur on which the patient was bearing weight. Why not arthrodesis? Because arthrodesis means iatrogenic fusion of the joint. You are obviously not going to fuse the joint. Why? Because it is criminal in this case. Today, we are not fusing the joint because it is restricting the overall activity of the human body. So, no arthrodesis of the hip joint. Only total hip replacement or girdle stone, and that too in those cases where the destruction of the joint has already happened. Then, for the management of osteoarthritis hip, obviously, if you can wait and watch, if the patient is managing it, then it's okay. Otherwise, you have to ultimately go for the total hip replacement. What is transient synovitis? As the name indicates, transient, because it was kept in one of your options. Transient means temporary. Synovitis means inflammation. So it is a temporary inflammation of the hip joint that usually happens in a younger age group. That means 7 to 10 years of age. It has a very short duration of onset, that means 7 to 10 days, that within 7 to 10 days it develops. It is a self-limiting condition where no treatment is required except for the provision of NSAIDs. That means you can give NSAIDs plus absolute rest, and over a period of time it improves. And it presents with the global restriction of the hip movement, because the condition will be extremely painful. You try to move it in any of the direction, there will be global restriction of the hip movement. And how the limb would be kept, in case of synovitis, synovium will be inflamed, so it will be kept in a position where the hip acquires maximum volume. And maximum volume of the hip comes in when the patient is having the hip joint in abduction, external rotation, and slight amount of flexion. So abduction, external rotation, and the flexion would be the attitude. So obviously this is all what you need to remember for the transient synovitis. Now go back to the question and we will come to know that how means, have we understood everything which is related to this particular question or not? If you go back to the question and read it again, it will make more sense. A 34-year-old male presented to the OPD with a complaint of progressive pain in the hip for the last 4 months. He reported difficulty in walking, experiencing pain while climbing stairs and getting up from the seated position. There is no history of trauma, but he mentions long-standing use of oral glucocorticoid. From here, you can think in the direction of osteonecrosis. Uh, Previously diagnosed autoimmune disorder. Now, on physical examination, there is restricted internal rotation and abduction of the hip joint. On that basis, you have already made your diagnosis that possibly the patient is suffering from osteonecrosis head of the femur. And when you see it on the x-rays, then it is very clearly evident that the head of the femur will or head of the femur is appearing sclerotic. The head of the femur is, all means, to some extent it is flattened, but most importantly there is still no reduction of the joint space. That means joint space is still intact. So the topic that we are dealing with is the osteonecrosis head of the femur. I don't know why, but I do think that this year possibly they will ask you a question on the differential diagnosis of the hip pain, particularly in relation to the management or the diagnosis or the appearance or the x-ray findings. And more than 2000 of such questions are already there in the app, which is launched by NEET Saviours for you to practice, which is best for final year MBBS students and interns, because this is how they will gain the sense that how these questions are getting asked in the examination, along with the critical explanation of how to rule out the other options and ultimately reach the diagnosis. So all the best for your future examinations. Prepare yourself well and stay confident, stay motivated. You see, no one can help you out in the sense of taking the credit. You yourself are responsible for structuring your own career in future. Thank you very much.